So coming to the next topic, that is surgical hematology, coagulation, bleeding and transfusion. This is physiology second part 1.2. So this is physiology as well as surgical hematology. So what is the composition of the blood? How is the blood composed? Total blood volume in the adult is approximately 5.5 liters. Blood is divided into plasma and cells. Three main types of blood cells are erythrocytes, leukocytes. Three main blood cells: erythro, leuco, thrombo. Erythrocytes, leukocytes, thrombocytes. These are RBCs. Leukocytes, these are WBCs, and thrombocytes is related with the platelets. So WBC has got then neutrophil, eosinophil, basophil, lymphocyte and monocytes. WBC consists of five different neutrophil, eosinophil, basophil, lymphocyte, monocyte. So leukocyte count means it includes all the things. Then what is the percentage of each cell? Neutrophil, basophil, when eosinophils increase, when basophil increase, when lymphocyte increase. These are WBCs, white blood count. These are the cells, and blood is composed of plasma and cells. And cells are erythro, leuco, thrombo. Leuco consists of five different. So plasma is divided. Then again plasma is divided into, blood is divided into plasma and cells. Plasma, what plasma has got? It is a protein rich solution. This contains more protein that carries blood cells and transport nutrients, metabolites, antibodies. This is very important. Antibodies are present in plasma. Hematocrit is the measurement of packed cells. Packed cell volume is basically formed by erythrocytes. So packed cell volume is basically RBC, PCV. It is usually 45%. Means of the total cells, 99% of blood cells are erythro. Over 90, so 2.5 liters of blood are from erythrocyte and 3 liters from the plasma. Of the formed by erythrocytes, and it is usually 45%. Over 99% of blood cells are erythrocytes. So 2.5 liters are from erythrocytes and 3 liters from plasma. So out of blood cells, 99% are erythrocytes, which is stem cells. All the blood cells originate from pluripotent. From where they arise? Stem means pluripotent stem cells in the bone marrow. At birth, bone marrow is most of produced cells. In adult, cell produces marrow remains in the eggshell skeleton, ribs, skeleton, proximal humerus, femur. Pluripotent stem divide early in lymphoid cells, which differentiate into lymphoid and myeloid cells, the basis of all the cells. So erythrocyte transport oxygen via hemoglobin. Basic function is, it is biconcave disc. Surface volume maximizes oxygen. Reticulocytes are called as immature erythrocytes. So whenever you see this word reticulocyte, this is immature. Their residual RNA lifespan is 120 days, broken down by macrophages within spleen, liver and bone marrow. Synthesis stimulated by erythropoietin. This is one question which is produced by kidneys. So hemopoietic cells, you can see this myeloid, lymphoid. Myeloid, you get erythroblasts, erythrocytes. Megakaryocytes, platelets. This is platelets, erythrocytes, and leukocytes they form. They are also called as granulocytes, blood granulocyte, basophil, eosinophil, neutrophil. These are granulocytes. And agranulocytes means they get monocytes, then myeloid dendritic and antigen presenting. These are also called as APC, antigen presenting cells. From the lymphoids, T cells, B cells, natural killer cells, and plasma dendritic cells. Antigen presenting, either they come from the lymphoid as well as from the myeloid. So monocytes, and from here plasma dendritic cells. Hemopoiesis B and T lymphocytes, they are coming from the lymphoids. So here you have seen they differentiate into leukocytes. Now just now we have seen 5 different cells. They are leukocytes. They form the defense mechanism, and erythrocytes is for the transportation of oxygen. They transport oxygen. Basic function is oxygen. and this is the defense. Transported in the blood, most function takes place when cells have left in the blood to enter the tissues. Neutrophil, basophil, eosinophil, lymphocyte. Together, neutrophil is basophil. These fills. You can see neutrophil, eosinophil, basophil. All these fills. Polymerase granulocytes. Fills, granulocytes. Due to presence of cytoplasmic granules. Neutrophils are 70 to 40 to 70%. Half-life is 7 hours only. They are fast-acting major cell in acute inflammation. This is a major cell. Very important role in bacteria. Migrate from blood to tissue via endothelium. So this is the main migration. They pass to endothelium. Lymphocytes. You see, lymphocytes are again leukocytes, WBC, white blood cells. They have got different types. Second most common, 20 to 50%. B cells, T cells, natural killer cells. Beta cells, B cells, second most common, important specific immune response. So these are the neutrophil directly attack, and they have got immune response. Three types of lymphocytes: beta cells, B cells, T cells, and natural killer. Sorry, beta no. B cells. Activated B cell convert into plasma cells. They convert into plasma cells. These are also called as antibodies or immunoglobulins. The hormonal response, that is immunoglobulins or antibodies. T cells produce cell mediated response. There are two different. B cells produce immunoglobulins and T cells produces cell mediated response. T helper in the three different ways. T helper, T cytotoxic, T suppressor, T cells, and they form antibodies which are called as immunoglobulins. This is important. While T cells, they form helper, cytotoxic, or suppressor, different types. This is the defense mechanism. The third different cells are, now you can see among these, we have read about fills, there are granulocytes, lymphocytes, these are defense, and monocytes. What is the action of monocyte? There are 15% leukocytes, largest leukocyte, mobile phagocytic. They just engulf and eat. Locate in the blood and bone marrow, precursor of macrophages are formed. Phage means phagocytic, to eat. So coming to fills, eosinophil, basophils. 5% leukocyte, they eosinophils parasitic against, and basophils probably mast cell precursor. They hypersensitive anaphylaxis and histamine release. Basophil related with histamine, anaphylaxis, and this with the allergies. So there is difference. Anaphylaxis and allergy is different. Hay fever, asthma, eosinophil. Asthma, eosinophil, and basophil, mast cells. Thrombocytes. These are basically concerned with the platelets. Their action circulate 8 to 10 days. Largest cell in the bone marrow, cytoplasmic fragmentation from the platelet plug. Their main function is from the platelet plug, endothelium. Surgery and general hematology. There are changes in the hematology response to major surgery includes whatever response there, leukocytosis due to increased neutrophil count, that is increase. Reactive anemia, chronic illness, blood loss, impaired erythropoiesis, serum iron is decreased, related to thrombocytosis. This is a response to surgery. Increased acute phase proteins include ESR and C reactive proteins. So what are different types of anemia? Adults less than 13, females less than male less than 13, female less than 11 can be anemia. It can be acute or chronic. Decreased production. There can be decreased production because of erythrocyte formation, impaired erythrocyte function. Formation or function. This can be decreased. Or there is loss. Blood loss, acute or chronic, decreased lifespan, hemolysis breakdown. Physiological anemia occurs in pregnancy due to relative increased plasma volume. Classify by the appearance of the cells. So blood film anemia can be classified into morphological. Depending upon their cell look at the mean corpuscular volume. Determine whether cells are too small is microcytic, too large is macrocytic, and normal size is normocytic. Intensity of the color depending on hypochromic and normochromic. Microcytic, small size, hypochromic cell appearance. The size is also small, and color is also less. So whenever there is iron deficiency, this is most common. Hypochromic microcytic, there is malabsorption, iron is less, chronic blood loss, GIT infections, genital tract infections, less intake of iron, increased demand. Whenever there is normocytic normochromic cell appearance, it is because of acute blood loss, endocrine malignancy, all this, hemolytic, erythrocyte abnormalities. So normochromic, normocytic, the size and color they are measuring. Not spherocytosis means size is not increased. Erythrocyte abnormality, GPD deficiency, sickle cell anemia, size they are not increased in size, but the shape is changed. That is sickle, spherocyte shape is changed, but anemia is there. DIC, loss or breakdown, infections, sequestration. So these are all normocytic, normal size and normal color in blood loss. All these spherocytes, ellipsocytosis, sickle cell, DIC, infection, all this, and macrocytic. This is a very important thing. Macro, when the size increases, megaloblastic, it is also called as the interference with the DNA synthesis causing morphological abnormalities. This is in the folate deficiency, vitamin B12 deficiency. This happens in pernicious anemia. Whenever patient has undergone gastrectomy, intrinsic factor is less, ileal resection, so B12 is decreased, Crohn's disease, drugs like AZA, hydroxyurea, methotrexate. Non-megaloblastic, liver disease, alcohol, megaloblastic, macrocytic, size increase, alcohol, pregnancy, hypothyroidism. So vitamin B12, folate, pernicious anemia, gastrectomy, ileal resection, large, all these lead to iron deficiency, micro, B12 deficiency, macro, abnormal shapes, normo. Only macro is immature cells, megaloblastic, size is increased. Effects of anemia. What has happens whenever anemia is present? Apparent when oxygen demand of the tissue cannot met. Tissues are in need of oxygen, but they cannot be met without some sort of compensatory mechanism. What is this compensatory mechanism? A slow falling hemoglobin allows tissue to acclimatize. Whenever slowly falling, a person acclimatizes. But sudden falling leads to tachycardia. What the body makes? Increase the heart rate, pumps more blood at the higher speed, increases cardiac output. And chronically reticulocytosis due to this is again immature cells they are formed. You want fast production of erythrocytes, so just release without fully matured cells. That is called as reticulocytosis due to increased erythropoiesis and increased oxygen extraction from the cell. When patient is relatively anemic and blood has lower hematocrit and decreased viscosity, this improves blood flow to the capillaries. So it is in cases of critical illnesses, patient require transfusion may not have anemia corrected beyond. Anemia is not a diagnosis. The patient presents with low hemoglobin. It is important to look for the cause. This is not the diagnosis. The cause is something else. It is the presentation. So you have to look what is the cause. When there is no time for further pre-operative investigation, correction of the anemia by transfusion may be required for research and surgical investigation ongoing. Reversible causes of anemia may be corrected before electricity. Mildly anemic patients otherwise may tolerate general anesthesia well. More profound anemia may need consideration of transfusion. Either you get blood transfusion, iron supplementation. Investigation. How to investigate a chronic blood loss, menorrhagia, rectal bleeding. You have to see and check whether insufficient dietary intake of the iron is there. Elderly people, poor, poverty, anorexia, alcohol problem. Excessive utilization of important factor whenever pregnancy, prematurity, there is relatively anemia. You check for malignancy, chronic disorders, malabsorption, drugs any person is getting, Further investigation of the anemia, it is important to look at the low hemoglobin level, HB level, is relation to leukocytes and platelet counts to consider a pancytopenia. If all the cells are decreased, it means pancytopenia. Reticulocyte indicate marrow activity. Tests for hemolysis include serum bilirubin. If unconjugated bilirubin is increased, it means breakdown is there. Urobilinogen and haptoglobin. A Schilling test is undertaken to suspect vitamin B12 deficiency. This is B12. A bone marrow biopsy may be considered thyroid function test, urea and other glutamyl transferase. Specific investigation for iron deficiency. Most of the patients having iron deficiency can be done by serum ferritin level, transferrin, and total iron binding capacity. Vitamin C increases iron absorption by unknown mechanism. So when you provide vitamin C, iron absorption is increased, the mechanism not known. So if you are to detect source of loss, investigation of renal tract, menorrhagia, replacement drug therapy, ferrous sulfate, ferrous fumarate. This has to understood. Ferrous sulfate, this impairs the absorption of other vitamins. So that's why ferrous sulfate has to be. Folate deficiency may be due to insufficient intake. Again, vitamin B12. Measurement of red cell folates, accurate serum level. Exclude vitamin D before admission of folate will aggravate neuropathy. Replacement of therapy should be consist of 5 mg of folate once daily. If possible, investigation should be sent off before investigation blood transfusion. So in nutshell, polycythemia. What is polycythemia? Is increase in erythrocyte concentration. This is the reverse of anemia. Is increase causing rise in hemoglobin and PCV. It may be primary or secondary, resulting in increased blood. This increases viscosity and predisposes to thrombosis. Polycythemia. What are the causes? These are again polycythemia rubra vera. Rubra vera. Excess erythrocyte production despite low erythropoietin is less, but still it is increasing due to proliferation of pluripotent stem cells associated with rise in leukocytes and platelets. Unknown cause diagnosed with hemoglobin more than 18, males and females. Secondary, this is primary. No cause is known unless erythropoietin is less. Secondary is because only increase in erythrocytes. Here is polycythemia rubra vera. All the cells are increased. Pluripotent. Here only erythrocyte. Appropriate increase in erythropoietin production is in response to hypoxia. So secondary polycythemia occurs whenever there is increased erythropoietin because of hypoxia, cardiac disease, pulmonary disease, smoking, hemoglobinopathy. This causes increased erythropoietin. So appropriate means sufficiently person needs. Inappropriate means malignancy is there, hemangioblastoma, renal transplantation, large uterine fibroids. So they may be secreting inappropriate erythropoietin. Relative dehydration, burns, plasma volume is decreased, they may lead to there is increased blood viscosity. What is the problem with this? Clinically leads to increased risk of myocardial infarction. Viscosity, circulation decrease, it may cause thrombosis, it may cause infarction, cerebral vascular accidents, deep vein thrombosis, hemorrhagic lesions in GIT, peptic ulcers. Rubra vera may result in acute leukemia, myofibrils. Surgery should be delayed if hematology is concerned. So now this was about anemia, polycythemia, neutropenia. Neutropenia is count is decrease less than 2. Neutrophil count. Neutrophilia is increase. Neutropenia is decrease. Severe neutropenia, neutrophil count less than 0.5, may be rare secondary to drugs or leukemia. And subsequent note, overwhelming sepsis can lead to failure of immune system dramatically low. So again, causes of neutropenia is congenital neutropenia are rare, more benign, if usually fatal in infants. Second neutropenia due to immunosuppressive drugs like azathioprine, antiviral drugs, zidovudine, antibiotics can give diseases like septicemia, leukemia, hypersplenism, viral infections. All they lead to coronavirus and all that. We are seeing that neutropenia is there. Count less than is severe sepsis, neutropenia infections usually disseminated, and septicemia. Hospital prophylactic measures, febrile neutropenia undertaken, consist of reverse barrier isolation, antifungal. These are prone for infections, so you have to take so much precautions. Neutrophilia is most common surgical condition. Any inflammation leads to increased first count of the neutrophils, result from metabolic disease. It also results from metabolic, hemorrhagic, poisoning, malignancy, and other causes of neutrophilia as acute infection. Bacteria is most common. Fungi, sporozoid, virus, and infections such as typhoid fever, paratyphoid, and tuberculosis usually not associated with neutropenia. Inflammations like burns, trauma, myocardial infarction, gout, glomerulonephritis, collagen vascular disorder, hypersensitivity reactions, post-operative neutrophilia may occur for 12 to 36 hours as a result of tissue injury. Metabolic response, diabetic preeclampsia, poisonings like lead, mercury, digoxin, acute hemorrhage, especially in the body cavities. Now coming to what is acute hemorrhage. That is peritoneal cavity, pleural cavity, joint cavity, intracranial cavity is associated with the leukocytosis and neutrophilia. This is probably related to adhesion, release of adrenocorticosteroids are adrenal secondary to pain and decrease of local inflammation. Malignant neoplasm, neutrophilia can occur as with rapidly growing neoplasm includes these thought to be the tumor necrosis factors are caused. Physiological neutrophilia, strenuous exercise, adrenaline is secreted, they cause. Other causes of Cushing's disease, corticosteroids, myeloid leukemia, and all this. The differential white cat count, helpful in elucidating diagnosis and form the bacterial infection. So you do which is the type of infection. Neutrophils normal range is 2 to 3. New lymphocytes is 1.2. So just now this is the table about leukemia. Decrease in leukemia, septicemia, and increase in infection, surgery, trauma, and all this. Severely increase in leukemia. So viral infection, lymphocytes, eosinophils in asthma and allergy. Basophils is urticaria. Parasite allergy is different. Basophil is urticaria. It is viral. But eosinophils in asthma and allergy. Monocytes, acute infection. So decrease now lymphocytes. We have seen B lymphocyte, T lymphocytes, and again T lymphocytes got natural. So lymphocytes decrease count is associated with opportunistic infections, bacteria, fungi, viral causes of lymphopenia, stress, trauma, burn, surgery, malnutrition, tuberculosis, HIV, sarcoidosis, primary. Lymphocytosis increases lymphocyte count may be because of viral infection, Epstein-Barr cytomegalovirus, chronic infection, tuberculosis. So you see lymphocytosis basis neutrophil lymphocyte counts. Thrombocytopenia. Now this is important topic for surgical. The low platelet count less than 150 includes production failure or survival or sequestration. Causes may be production failure are aplastic anemia, drugs, cytotoxic, alcohol, viral infections. Decreased survival is killing of this. There are drugs like heparin, which are used, gold, penicillins, infection, bacterial meningococci, thrombosis, blood transfusion, hemolytic uremic syndrome, sequestration of platelets. So hypersplenism, they causes platelets get sequestered, count becomes less than this. These are the conditions. Clinical condition in thrombocytopenia. What happens in thrombocytopenia? Platelet dysfunction is there. So excessive surgical bleeding. So this is the question. Platelet dysfunction occur in normal platelet count. Platelet count is normal, but it is not functioning. The most common cause of surgical bleeding is antiplatelet. Whenever you are giving mechanism antiplatelet medications like aspirin, clopidogrel, these are the most common antiplatelet drugs which are given to the patients preoperatively, which are getting both aspirin and clopidogrel should be stopped at least 7 days preoperatively to restore normal platelet function. They should be stopped. Disseminated intravascular coagulation. This how many days before? In the most of the questions, it is 24 to 48 hours. We will just revise it when you get disseminated intravascular coagulation. What is one is platelet dysfunction. DIC, there is simultaneous activation of coagulation at one side and fibrinolytic system in the body causes widespread microvascular thrombosis. Anywhere there can be thrombosis, fibrin deposition, bleeding due to consumption of the factors. TTP, thrombocytic thrombopenic tuberculosis. This condition affecting young adult deposition of the widespread hyaline thrombo and small. Hemolytic uremic syndrome usually occurs in acute illnesses, URTI, GI infection, E. coli infections, microangiopathic hemolysis, thrombocytopenia, and acute renal failure. ITP is destruction of the platelet due to IgG antibody attack. Two types exist: acute hemangioma purpura and post-viral occurs in adults. Thrombocytosis. means increase circulating platelet may be primary, secondary, may be inactive. Causes thrombocytis primary is essential thrombocytemia, results from rubra polycythemia rubra vera. All the counts are increased. Secondary is reaction to hemorrhage, connective tissue disorder. Whenever there is splenectomy, there can be thrombocytosis. As patients who have thrombocytosis are risk of thromboocclusive disorders such as risk of DVT is there in vast graft syndrome. Pancytopenia, all cells are decreased. Global erythrocytes, global platelets, these are bone marrow infiltrates, anemia, thrombocytopenia. Causes of pancytopenia, bone marrow depression. Most common pancytopenia while in the most common cause of while in the hospital include cytotoxic drugs. When you are giving immune suppressant or antiviral drugs, you get all the cells get decreased. Megaloplastic, aplastic reduction in pluripotent cells. What is the effect? It require transfusion of to maintain hemoglobin. Clinical effects: repeated transfusion may drop platelet count. Neutropenia may require neutropenic regimens. Thrombocytopenia, sickle cell disease is a cause of genetic mutation, inherited, causing changes in the hemoglobin structure, altered hemoglobin binding, homozygous and heterozygous sickle triad. The disease epidemics are Africa and also found in India and Middle East. So clinical problems include hemolytic anemia, genetics of sickle cell. At birth, majority of the hemoglobin in the body is fetal hemoglobin. So at birth, it is hemoglobin F. By the age of 6 months, all this F is replaced by adult hemoglobin. So hemoglobin fetal has got hemoglobin is made up of two chains, two alpha and two beta chains. The inherited genetic mutation of alpha chains leads to formation of sickle cell. This single amino acid glutamine at the position 6 of beta chain is replaced by valine. So glutamine is replaced by valine, and this causes oxygen. Sickle cell hemoglobin can present as a triad, heterozygous, homozygous SS. The disease at the month of 6. Deoxygenated hemoglobin is insoluble and polymerizes causes red blood cells to form rigid, inflexible, low oxygen tension while traveling through the capillaries, causes rectal cell shape, results in hemolytic anemia and secondary pigment gallstones, and infarction, ischemic pain, especially finger, dactylitis, and priapism. Sickle cell disease surgery, diagnosis of full blood count, peripheral blood count is confirmed by him. It is important in surgery to avoid precipitating factors include hypothermia, hypoxia, dehydration, common in surgical patients. Sickle triad is symptomatic. Thalassemias are disorders of defective synthesis of globin chains of hemoglobin. Now this is globin chains of hemoglobin caused by hemolysis, anemia, erythropoiesis. African Middle Eastern condition, thalassemia major, thalassemia minor. The most common thalassemia is minor is heterozygous state and is produced in microcytosis. Beta major is homozygous form, and there are much related number of patients, failure to thrive, recurrent infection. The aim is to hemoglobin more than 10 has to be there. Alpha 4 chains are responsible for alpha chains. A disease is caused by genetic deletion. All 4 are deleted condition fatal. So hemostasis and coagulation. This I will discuss thalassemia in detail in another chapter. Hemoglobin HbC causes mild hemolytic anemia. HbE causes mild microcytic. So then there is hemostasis and coagulation. This is important part. These are all coagulation cascade. Acquired disorders, vitamin K, thrombotic disorders. Conditions associated with GIC, virtuous triad, related to risk of thrombosis. Let me see how many pages are there. When can we cover this? Is Wells criteria. So I will stop this part here, and this will be covered in the next part. Basically, that is longer, and we have to do in a very systematic manner. This large chapter, so I will be stopping here.